right down here with us.
So I'm
today.
Nirali Vora. I'm a stroke neurologist here at Stanford, and I was honored to be invited to be a part of a co-chair with Dr. Evelyn Stock at UCSF for Cardiology to co-chair this Silicon Valley University of Best Practices that Abby Henley invited us to as part of the RightCare initiative. And I've been really inspired by this group, some new faces I see, so just to catch you up, that we've been really trying to bring together all the great minds and great interveners for this region to think about how to get towards zero preventable heart attacks and strokes. And I think that over time we've found a nice pattern in getting our great science to speak about some of the advances that we've had in this area, often led by local, scientists, as we're going to hear today from Dr. Kanaya, as well as from either some form of implementation. So whether it's a community-based partner, like we're going to hear about from the South Asian Heart Center, or a technological partner about some sort of device intervention, these things have all helped inspire us to think about how we can do better. And so we view ourselves as sort of moderators of this great discussion, but we really invite a lot of discussion, so please speak up. And usually we just do a brief around the room intro to sort of say who we are and either what we're hoping to accomplish or how, in this particular topic of combating excess risk of diabetes and cardiovascular disease in South Asians might be relevant to you or what you're hoping to learn so that we can guide the speakers. And so myself, as a South Asian, obviously I care about this topic tremendously. Dr. Palanithian, who's a cardiologist here at Stanford, got me interested in this when I was an undergraduate at Stanford, doing cardiovascular disease prevention akin to kind of what South Asian Heart has been doing in the community. And I think that stuck with me, and even though I didn't realize it at the time, I think it's what inspired me to go into stroke neurology in a way and continue with public health efforts. So maybe we'll start with Dr. Molina.
Well, I'm César Molina. I'm a cardiologist at Alka Hospital. I can tell you that I started my internship in 1980 in that building over there. And on my first day of internship, I met the woman who then became the mother of my two children. On my first day of work, but I'm glad to be here, and I hope I can show you what we can do in South Asian Heart Center down the street.
I'm Evelyn Stock. I'm a preventive cardiologist. In my other life in Chile, I was an endocrinologist and then trained in cardiovascular diseases. And my mentor, Dr. John Kane, is here, and he's got me into lipid metabolism. And we work mainly as molecular scientists, trying to find out mechanisms to prevent heart disease. That's our big motivator, and we're very interested in South Asians. We see a lot of these patients, unfortunately a little too late, but we're hoping we can get them early and prevent disability, so we're very excited.
My name is Ashish Mathur, and I'm the co-founder and executive director of the South Asian Heart Center. Unlike most of you here, my background has not been in healthcare until we started the South Asian Heart Center at Camino Hospital, and it was more because I was a patient first of heart disease that drove me to look at this for the community and see if there was a way to address it in a larger population. So I'm very interested in thank Alka and the team here to invite us. Dr. Molina is going to present what we are doing in the community.
Hello everyone, my name is Arnaud Mukherjee. I'm a professor of health sciences, particularly public health at California State University East Bay. I'm here to see my wonderful mentor, Dr. Alka Kanaya, so that's the most important thing for me. My research interests broadly focus around preventable health disparities among South Asians, with an emphasis on the intersection between culture and behavior and the environments in which they occur. More purposefully, I'm here to sort of bridge the divide between sort of the research university world and the non-research university world. So one way I hope to do that is to bring my wonderful cadre of students across the bridge to see that this is actually a career that's worth pursuing, that aligns with their values and their passions.
Hi everyone, my name is Veda Kumar and I am a professor of nutrition at San Francisco State University. I am here for two reasons, because two of my mentors are here, Arnaud and Dr. Kanaya, who for her study, masala study, I served as a project manager. So I have done some nutrition work for South Asians before, and I'm in the field of nutrition, so it's very important, and I want to see the nutrition piece brought in with heart disease, diabetes for South Asians. So that's where I come in and wanted to attend this meeting.
Hi, my name is Faryal Irfan, and I'm a former student of Dr. Mukherjee and a current research assistant for him. So I'm particularly interested in the role of culture in health, particularly in the South Asian community, which is why I know Dr. Mukherjee so well. And here today, I'm just here to learn and observe.
Hi everyone, my name is Shabana Ali. I'm a student at Cal State East Bay. Professor Arnaud Mukherjee is my mentor, and I also do research with him as well. I'm interested in the Fijian community, making sure that our voice is heard and that they're not blended into the Indian community because they're not that predominantly known.
Hi everyone, my name is Priya Raman and I'm also a student here at Cal State East Bay. And I also work under Dr. Mukherjee. And yeah, just like Shabbat said, I'm also interested in making sure our Fijian Indian population's voice gets heard in the atmosphere of South Asian health.
Hello, my name is Pooja Lal and I'm also a student at Cal State East Bay, and I'm a researcher under Professor Mukherjee, and I'm a health science major, and we're just trying to make sure that our voices are heard within the Indo-Fijian community.
Hi, my name is Justin Kalika. I'm a medical science liaison with Novo Nordisk Pharmaceuticals. This is ideal to our company as we're a diabetes company and have evolved into cardiometabolic disease. Certainly expanding our clinical trial demographic is aligned to trying to include more of an ethnic diversity. So this is a great collaborative opportunity for me to meet each and every one of you and potentially think about some potential partnership opportunities and collaborative efforts to make some strides and improvements in this these initiatives. So thank you.
Hi, I'm Evelyn Michaud. I'm a medical science liaison with Janssen, part of Johnson & Johnson. So following Johnson & Johnson's credo, I've mentioned this in the past, this is our place to listen to providers and the patients first. So I'm here to learn and see how we can partner and bring the medicine or device we have to a better place and provide better value with what we have now and better research.
Hello, I'm Angie. I'm a registered dietitian over at UCSF. I work in the preventive cardiology clinic with Dr. Evelyn Stock, and I'm just here to learn more. We certainly have our fair share being in the Bay Area with South Asian populations, and I certainly help to counsel them in diabetes management, hypertension management, heart disease. And so, one of the questions that I get asked all the time is, why do I have heart disease? Because, or why do I have diabetes? Because I follow a good diet, I'm a vegetarian, and I'm at a normal body weight. So I'm just really eager to be able to find out some more strategies for screening and better counseling for the patients.
And I'm Dave Abramson. I'm Vice President of Medical Affairs at a company called Ameren. I'm a cardiologist by training, and our area of research, which is very relevant to the Southeast Asian population, is the effects of triglycerides and triglyceride-rich particles and the effect on the atherosclerotic effect. We've studied, and I know Dr. Stock had asked me to make a few comments. We completed a landmark trial and presented it at American Heart in November called the Reducer trial. This study showed that very high dose of EPA, eicosapentaenoic acid, had a remarkable additional lowering of CHD, death, MI, stroke, revasc in a very well-controlled LDL population. So there's obviously something there. And unfortunately, only 2.9% of our population in that study were Southeast Asian. to try and
study is going to be.
well, and so Justin already mentioned that unfortunately in clinical research we often have this disparity in terms of underrepresentation. So two things that we are doing: we're partnering with the Department of Defense to look at African Americans and women. We had 29% female cohort, who by the way did very well, but we need more data. And then very excitingly, this is fresh off the press, we've just started a study with Kaiser in Southeast Asians. They have the biggest database available in the United States. So we're going to be looking at all these different lipid variables, looking at CV outcomes, and hopefully actually working on developing algorithms to address this. So really nice to be here. Thanks.
Well, I'll start by telling you I'm Dr. John Kane. I'm a professor of medicine and biochemistry and biophysics at UCSF. But I'll start by telling you that I'm descended from my mother's Irish family that spent 30 years in India. And her grandfather was the Irish engineer who was responsible for building the docks at Mumbai. And so we had a lot of interaction with Indians from many, many years. And but as Evelyn indicated, we're very molecular. We try to combine clinical observations with genomic ones. We found a number of genes. We found the FOL family, for instance, and you never know what you're going to find because one of those genes turned out to produce the protein that kills the trypanosomes of African sleeping sickness. And so you discover a protein, then you find out what it does, or a gene. And but we've discovered genes, we've discovered populations of lipoprotein particles, especially among the HDL. A lot of people refer to HDL as an entity. We think there are about 25 molecular species and doing a lot of very different things. And so we are very interested in the population from India. And recently I've been making the observation that we're finding people with phytosterolemia. And I don't know how well that's known, but we've already found several people in our clinic. And this is a genetic defect in the protein that transports these sterols into the body. And so we really like to do molecular studies and would love to incorporate them into epidemiologic studies that you may be conducting.
Hi, my name is Jack Westfall. I'm a family physician. I spent 25 years at the University of Colorado Medical School, moved here a year and a half ago, and I'm the medical director for our whole person care program for Santa Clara County Health and Hospitals, and split my time in the public health department as the medical director for the Healthy Communities branch. My job is to cross the boundaries between health and hospitals and learning health systems and the community, and what's going on with both governmental public health and community-based organizations.
Good afternoon. I'm Edu here. I'm also a family physician by training, serve as the Chief Quality Officer of Apollo Medical Foundation, and here to learn from all of you, do the sciences and we apply it to our patients that we serve.
Hi, I'm Jamal Rana, so thanks for my invitation today. I'm Chief of Cardiology at East Bay Kaiser Permanente. I'm also a adjunct investigator with the Division of Research at Kaiser Permanente. So my research, I'm interested in many things, including lipids, metabolic dyslipidemia, and imaging with coronary calcium scanning. But I feel that South Asian research needs to be done more, and there's a lot out there which is not underreported and not discovered enough, so I'm very interested today. And I was just talking to Dr. Yu that for the first time, American College of Cardiology has recognized South Asians as risk enhancers. So I think that's a first good step. So I'm very excited to be here.
And hi, I'm Alka, and I'm Professor of Medicine and Epidemiology at UC San Francisco. Sorry, frog in my throat. And I'm a general internist, and this whole idea of South Asian prevention of diabetes and cardiovascular disease is personal to me, as well as clinically important because of the patients I see and serve, and I will show you some of our data.
Hi, everyone. I'm Dr. Duran. I'm a practicing endocrinologist in the East Bay, and certainly have also very strong clinical connection to serving a community that seems, as I agree, excess risk, well put, for diabetes, cardiovascular disease. Yikes.
Oh my. We'll take care of that.
I hope that's okay. So yes, I'm excited to hear your presentation. I have many patients where I feel like I'm doing everything possible with every pharmacotherapy, lifestyle intervention, and still this increased risk and end-stage complications. It's very, very clinically challenging. I also serve as vice chair of the American Diabetes Association Community Leadership Board, so definitely have an interest in taking what I see in clinic as well as what I learn to more of a public policy forum. Thank you.
I can't see you, so I'm going to stand up. I'm Lynn Trine. I'm with Trinomics, which is a health tech company startup. And, well, actually, I am not a medical person myself, but I do have a South Asian medical background because I grew up in a household with a father who formed a nonprofit organization to raise funds for building a small clinic in India in Amati, South Cork. And so my childhood growing up was back and forth, him going back and forth, and many Indian doctors in the household. So I feel kind of an affinity with many of you here today. So thank you.
Bob Trine, entrepreneur and focused on the reduction of the impact and incidence of chronic disease, particularly metabolic disease. So together with my partner, Dr. Krishnamurti in New York, we are introducing an apologetic risk score that developed at Cambridge and Baker Heart and Diabetes off the UK Biobank into the US. And that is primarily, Northern European, about 18,000 South Asians in that, but not a lot of incidents. So we are continually looking for opportunities to expand the data set. We know that just by mathematically adjusting for ethnicity, we can improve the risk scores quite a bit. So we're just always looking for more data to add to that puzzle.
Thank you for flying up from Los Angeles to be with us, Trine family, great do-gooders in the community. And they didn't mention, but they've worked to start a mobile screening unit in Santa Clara County to take it out to the family community, to community centers, to do proactive genetic and heart CT screening in collaboration with No More Broken Hearts, which is a group that started because of a young, very young death from a seemingly very healthy person, an Apple engineer. And so what we're trying, so my name is Hattie Hanley. I'm the founder of the RightCare initiative. We are a collaborative that works statewide, and we have 4 regional groups. The first one we started with an NIH grant in San Diego, and we showed that over a period of 4 years we reduced mortality and acute myocardial infarction hospitalizations 20% faster than the state trend, and very, very rapidly, simply by doing what we knew then, because we started that group in 2011. This is our 4th group. In that group, we simply said to the health systems, let's share best practices to get those patients who are known to have cardiovascular disease, hypertension, or diabetes to goal for those 3 magic metrics of blood pressure, lipids, and blood sugar. And through sharing best practices, we were able to get all the groups in San Diego to much higher levels of control for those 3 metrics. We've yet to do the study that would really tease out what the, which of those 3 really drove what, and I think that they just work in tandem is the fact. Increasingly, our co-leaders from our various communities, so we started in San Diego, then Sacramento, then LA, now here in Santa Clara County, and we'll hope to go Bay Area wide in time. Increasingly, our leaders are also moving to the national level, so I'm very happy to report that at the end of June, we were able to relay this information to the U.S. Surgeon General and really implore him to put some financial resources on these three metrics, because not only did we find that there were 3,826 fewer acute myocardial infarctions than were anticipated over that 6-year period, and as is published in Health Affairs, it also saved $86 million. And that, if scaled according to RAND analysis, would have saved $935 million, just shy of $1 billion statewide. Now, if you scale that to the nation, not only do we save money, we save lives, and like you, it's not only professional, it's also personal. So I promised myself and the powers that be that if I got into Harvard, I would use my training to spread best practices to prevent other families from going through what my family went through when my mother died suddenly of a stroke when I was 15 years old, because she had hypertension and did not know it. This is something that we know how to do. We know scientifically in America what to do, and we need to get over the clinical inertia and the complacency around those three risk factors. And we're going to learn so much more today from Dr. Kanaya about the particulars of this very high-risk group. And so I would just urge you all to not accept this being high risk, and let's make doing the healthy thing the right thing to do. So what we were talking about in our steering committee meeting is, if we learn that, for instance, unhealthy fats in the vegetarian diet are contributing to this higher risk, then let's teach cooking differently. Let's take action and not just accept that the high risk has to remain high risk. And with that, I'm going to give it to our chairwoman.
Are we inspired or what? Thank you all for being here. I think each of you contribute something really important to the questions and the solutions that we're talking about. And I could just, when each of you did your introduction, I could just see how, wow, all of us working together from all aspects of the healthcare spectrum, in whichever way you touch it, is really going to help make change. And so I'm excited to introduce Dr. Alka Kanaya, who can come to up here now. You heard a little bit about her. So she did her training at UCSF in internal medicine and epidemiology, and has really made it her career now as a professor at UCSF to work on this issue of what is the driving force behind cardiovascular disease and diabetes in South Asians. And really, you know, this Masala study that we're going to hear about, the first of its kind, looking at longitudinal effects on this population, is going to be just so exciting to hear about. So I'm actually just going to give you the microphone because I can't wait to hear it.
I'm going to give you the talk without slides. Let's see how this goes. What?
We'll get them up. We'll get them up.
Okay. I can run and get my PC from my car. Does anyone else have a laptop?
We have a laptop.
And I have a.
So it's great. It's not going to accept the connection.
Maybe it's a Mac.
Well, they try to work that out. How about if you just speak about your knowledge, and they'll figure it out. They're super smart. And maybe, Bob, can you try to add your super brains to that equation, since I have none to add there.
Well, I'll tell you a little bit of background on how Masala started. So Masala stands for Mediators of Atherosclerosis in South Asians Living in America. It's the first longitudinal study, epidemiologic study of South Asians in the U.S. We currently have 1,164 participants, and we've been following them since 2010. So it's about 7 to 8 years of follow-up on average. And the goals of this study were really to understand why there is so much more cardiovascular disease and what we can do to make this better. How can we prevent it? So we, I think the best mentorship I ever got was from my former mentor who just died this year. Her name is Elizabeth Barrett Connor. professor at UC San Diego, and we were at an AHA meeting. We were sitting in the lobby of the Fairmont Hotel in San Francisco, my first AHA meeting, and we're talking about brainstorming ideas. And I said, you know, a cohort of South Asians is so needed. There aren't any in the world. Can you believe this? Quarter of the world's population. Oh my God. Okay. And she said, well, I don't think just a freestanding cohort of South Asians will work for the NIH because, you know, it's 1% of the US population. You have to really have buy-in from the reviewers that this is important. But if you leverage another ongoing study, like the multi-ethnic study of atherosclerosis, that has 4 US ethnic groups, and you kind of create a parallel cohort so you can cross-compare, that may be a better idea, and that might actually take traction. And that was the impetus of the idea for my pilot study as a K-23 Career Development Award, and then that was later funded to actually fund the study, so I think that's a very common. So with that, thank you. Okay, great. Okay, great. So just to show you some US mortality data, and this comes from 34 states that looks at different Asian ethnic groups, and the colors show you Asian Indians are in light blue. I don't think there's a pointer. Okay. And basically, if you look at the left panels, women on top, men on bottom, the light blue line is the highest, and that is just showing you rates of cardiovascular disease mortality in compared to whites and Filipinos, Japanese, Vietnamese, Chinese, and Koreans. So we know that the rates are high in the US, and they've been high in other countries where South Asians have immigrated to, like the United Kingdom, like Singapore, like Fiji, other places that have some data, but we really don't know why. So that was, again, part of the whole understanding here. This is taking a little time. So the aims of the Masala study was to establish a prospective community-based cohort of South Asians to determine lots of reasons why. So we did a very kind of deep dive here. We wanted to know what traditional cultural risk factors, sociocultural, behavioral, novel, other biologic risk factors were associated with subclinical atherosclerosis, the first steps of clinical heart disease, and type 2 diabetes. And then we wanted to compare the prevalence of this in the South Asians to the 4 groups in the multi-ethnic study of atherosclerosis. And then the long-term goal is to really see what factors are predicting cardiovascular disease risk. So in order to do this study, we again partnered with MESA, and we designed the study very similar, using the same inclusion-exclusion criteria, only that they had to be South Asian to be in Masala. We went with a slightly younger age, 40 to 84 rather than 45, just because knowing that heart disease and diabetes happens at a younger age, so let's start a little bit younger. I would have liked to start even younger, but you can only do so much in the confines of an NIH grant. So we had enough money for 900 people to be in this cohort. They could not have any existing cardiovascular disease. And I want you to remember that as I go through this, because we're looking at antecedents of disease. So we had to exclude people who'd already had stroke, heart attack, any kind of procedure on their heart. And if they even had an angiogram with no disease, they were excluded because somebody's already taken a look and they've already started to potentially change their habits because of the fear of this. So we really wanted a healthy cohort. They could have any other metabolic disease, of course, but they couldn't have had cardiovascular disease. So keep that in mind, because basically the data that I show you that comes from this cohort is probably the best case scenario, because it's coming from the US. It's coming from people who have immigrated to the US with the healthcare system and environment we have here, as well as people who already didn't have heart disease and they're already in their 40s, 50s, 60s, 70s, and 80s without existing cardiovascular disease. This is exactly the same definition of eligibility that MESA used, and so partnering with MESA, we had to use that definition. So we had 2 sites, UCSF and Northwestern, our Chicago partner, and then I did that pilot study in 2006 where we generated great data to make this feasible. And the baseline exam we finished in 2013, and we just finished exam 2 last year. And you can see MESA started 10 years before us. They had a lot more money. So we had 6,500 participants in 4 race ethnic groups in 6 sites, and they started in 2000. And we have been very parallel to them in the types of measurements we're making. So just giving you an overview of what we've done so far. The first exam was in 2010 to 13, and we brought people in. We did a random sample of people around the Bay Area, 9 counties. We set